In public health, we talk a lot about the metaphor of seeing someone in the river and pulling them out, and then finally going upstream and understanding why someone fell into the river and helping to build the bank or to fix the bridge or whatever metaphor you want to use. In the emergency department, I feel like I work pulling people out and then my day looking at the bridge. And so I literally get to walk up and down this bank of public health to healthcare system and see what's happening and how it falls. I say, who's in charge of this mess? Oh, I am.
Welcome to The Other 80. I'm Claudia Williams. A couple episodes ago, I talked to Dr. Tomas Aragon about lessons from COVID from California, our nation's most populous state. And today we're talking to Dr. Ann Zink, who helped lead the COVID response in one of our least populous states, Alaska. During the height of the pandemic, Ann Zink was an emergency room doctor and the chief medical officer for the state of Alaska. To protect her family, she would quarantine in a backyard yurt after shifts in the ER. It was from that wood stove heated yurt that Dr. Zink worked hand in hand with the governor to lead Alaska's COVID response. And she became a viral sensation along the way, inspiring both a Facebook fan group and the hashtag #ThinkLikeZink. When you meet her, it's easy to see why that happened. I sat down with Ann in person at Vive 2024 in Los Angeles this past February. So please welcome Dr. Ann Zink to The Other 80. Hello. It's so fun to do this across a table versus across the internet. So thank you.
So great.
Thank you for being here.
Yeah, I'm excited.
So we are at the Vive conference, and you were just mentioning that it's wonderful to have public health in these broader conversations about health technology innovation. If you could share one thing with the whole Vive audience, what would it be?
Well, I am just so thrilled that you asked me to be here, and I would share with the whole Vive audience what I am sharing with you, and that is that public health is population health. And if you want to make a difference in what we need as a health system, public health and healthcare have to be braided together. We need to not think about this in terms of separate systems, but we need to think in terms of patients. And to get there, public health is that key chief strategist for population health and needs to be at the table.
I love that. We'll be returning to that concept. What's something we really need to know about you as we launch into this conversation?
Great question. I've loved listening to your podcast and what other people have shared. I think I would share my professional motto. I had an attending in residency, and he said, Ann, do what's right for the patient and remember that the rest is noise. And I think that really having that hyper-focused clarity of what do people need, that human in the center nudge, how do we build really those humans, patients, components to everything we do is critically important. And so that is kind of my professional motto, be it what I do at a national policy level or what I'm doing on a night shift in the emergency department is how do I collaborate my resources, make systems work for the patient rather than asking patients to take on the burdens of our systems. And remember that there's a lot of noise, but ultimately it's doing what's right for each other.
So one of the tidbits I pulled up from your background made me smile this morning, and that was the trip you took to Botswana, Nepal, and Antarctica, I believe it was, because I was a Peace Corps volunteer in Botswana.
Oh, no way.
That was part of your pathway into your current role. What was it you learned or saw or experienced on that trip that has brought you here today?
Yeah, thanks for, that was a while ago. So I was an inorganic chemistry major and fine arts minor in college, wasn't sure what I wanted to do. And my advisor encouraged me to apply for this thing called the Watson Fellowship. And Thomas J. Watson took IBM from a typewriter calculator company to what it was after this year that he traveled abroad. And so he encouraged others to do the same, and he created this fellowship called the Watson Fellowship. So I did that, and I was looking at the impacts of tourism on culture and environment. And I traveled all around, worked in many of the countries that you talked about. And that's really where I found my love for medicine. And I think it was really that connection between people and places and just the really human experience and how the science and the data can blend with human experience and story that I really just fell in love with. And I, despite my best efforts, kept finding myself working in health centers and realizing that that really was my passion place and love.
Before we jump into COVID and your role guiding the state through that, You work in a yurt, I believe, outside your house in Alaska. Paint the picture for us of your daily routine in that space.
Yeah, thanks. I mean, I was a mountaineering guide during college and met my husband up in Alaska. Went to med school, residency, and afterwards we had two small kids. He said, let's just go back up there. I said, I'm really interested in systems work. I'm interested in academics. I'm not sure Alaska's the hotbed for that. And he said, let's just go for a couple years. So I said, okay, we'll go for a couple years. I joke that it was as urban as he could live and as rural as I could work. And we chose to go back to this area called the Matanuska Valley. And so I work in a place called Palmer, Alaska. It's about an hour north of Anchorage. And just totally fell in love with the people and the place and was able to do a lot more systems work. Long story forward, family would come up and visit. We didn't have a guest room, so we put up a yurt in our backyard so that our family could have a place to stay that felt like a space for them. Fast forward through COVID, I was working in the emergency department and was the chief medical officer for the state. And so I needed a place to be able to work, but also quarantine from my family after I worked in emergency department shifts. And so the yurt became a place that I could sleep and eat after I had worked shifts, and I would quarantine for 2 weeks after my shifts away from my family. And most of our press conferences were all via Zoom and live. And so the world became very aware that I worked in a yurt during a press conference when the governor said, Anne, are you in a yurt? I was like, I am.
Yes, I am.
Sir. I didn't realize you could notice the lattice structure. So I never thought that, Jill Biden would know me as working in a yurt. But when she came to Alaska, that's what she referenced. And so somehow our guest bedroom / office space, I now usually work in the house because I don't need to quarantine from my family in the same way. And it's used much more as a guest bedroom these days. But it
is your work
here.
It is
my work here.
That reminds me of conversations I had with family in Maine about their public health officer, Dr. Narav Shah, because he became this sensation. Everybody would listen to him. Everybody loved him. There were memes about him and all that. He now works at the CDC. And similarly, in Alaska, you really became a folk hero in the state and really lauded for your communication and your care and attention to how to communicate about this important crisis. What did you learn about communicating in crisis and about public health communication in general? And are there any anecdotes you'd like to share about being this sensation in the state?
I took this role in July of 2019, perfectly timed right prior to a worldwide pandemic. It was not what I was anticipating. I wasn't expecting to be in the media and involved nearly as much in communication. I think a couple different things. First of all, as an emergency medicine physician, we spend on average 2.5 minutes with a patient. It's incredibly short periods of time. And you walk into a patient's room, they're in a gown, and they might tell you stuff that they haven't told their spouse. They haven't ever told anyone else. They're suicidal. They've been having chest pain for weeks. And you have to very quickly build trust, build empathy, and really listen to what their challenges are and being able to come up with a diagnosis and next steps. And my work, particularly during COVID in the state, felt very similar, that I very quickly had to talk with people, learn what their concerns, their fears were, be it schools or be it a seafood processing plant or be it my epidemiologist or be it the governor. And just like in the emergency department, I am not the surgeon, I'm not the family medicine doc, I'm not their family, I'm not the expert at any one of those things, but I am there to help bring those pieces and tools together to really do what's best for my patient. And my work as the state was very similar. Again, I'm not the epidemiologist. I'm not the superintendent of the schools. I'm not the governor. But my job was to take all of that information and try to share it in a way that people could understand and be able to respond. I think a couple things that I learned. One, you can never communicate enough. There's no secret sauce to this. It takes a lot of time. It takes a lot of effort. I think that communication is more than just speaking. It's also listening. And I loved on one of your podcasts, someone had talked about listening loudly. And I love that. Like, how can you really lean in and listen well? I also think it's about not always having you be the voice. So for example, any community, when they first had a COVID case, it wasn't the state sharing that. What we would do is we would say, who are the leaders in that community? And it was usually a tribal leader, an elected leader, like a municipality elected leader, and then the healthcare leader. And we would get together with a meeting with them and say, what's the main form of communication in your community? And it might be ham radio, it might be Facebook, it might be regular radio, a TV show. Everyone was different in their community. And we said, we want you to share the information. What does your community need to know? What resources exist in your community? And we're happy to come on and be there and say, and we're here to support your leaders. And that really made the local leaders be the voice and be the advocates and could speak to those local resources. So that when we were having to speak in the next community, and the next community, and the next community, those local trusted voices were the voices that were able to continue to message and to partner. But it was clear that they were not alone, that we were there and they knew had our number, that we had theirs, and we were there to work closely together. So I think part of communication is allowing other people to be able to speak in that role. I also would say that I really appreciated the fact that every single day, the governor and I would both be on, and we have really different skill sets and we have different perspectives. And he would speak to what he saw, but he never told us what we could or couldn't say. He let data speak and science speak, and we could share our perspectives of what we knew about the virus or not. And that was a real gift that not every state had, not every state health official had. I have very little authority in the state of Alaska. I would joke that my only authority was the authority to Zoom. I didn't have the authority to do much else. And so I had to really lean in to communication because that was the one tool that we had. But the benefit of that is that by explaining something, by helping to share that information, then communities owned it. And so we had very few restrictions. They very quickly came off. But that we had honestly incredible outcomes compared to what we could have had compared to the 1918 pandemic. We were the most tested state in the nation for over a year and a half. We were the fastest state to get out vaccines. There was incredible work that happened. And if you look at our case fatality rate, it's significantly less despite our really limited healthcare infrastructure than most of the lower 48. And so that deep investment in education, I think, paid off for a really long time and has continued to pay off. And that commitment to community partnership and listening, we're very much trying to continue that process now. So we built our tribes into our vaccine response team. They sat on every single part of our response. We're doing a big youth mental health roadmap right now. And we went to 5 major regions and listened to the community, had night sessions where we listened to family members, students, counselors share their experience. And that has made us so much better at the state in figuring out how to respond. So I think we've taken a lot of that really listening loudly and structured it, because then we're able to speak to it in a different way because we've been able to hear from community, from their experiences, and having that constant two-way feedback. The last thing I would add is I think working as an emergency medicine physician was hugely helpful during that time. I work in a region that is one of the least vaccinated areas of the state, and there's a lot of skepticism. But being able to sit side by side, looking at someone in the face, hearing their story and concern is very different than when someone's a number. And I got so much value out of hearing patients' concerns, their frustrations, their fears, that made me a better health official, a better communicator, because people are people and they're making the best decisions they can with the information that they have. And that information can be imperfect and they can have other barriers to their decision making than just reducing COVID. They can't afford to lose their job. They have got to get their kids to school. There's huge other pressures on their life. So being able to hear that, understand that, I think helped to figure out and to just listen to lots of stories from people.
And I think there's been a lot of concern about attacks on public health professionals, but also lack of public trust coming out of COVID and feeling like they were either misled or that they thought it was one thing and turned out to be something else. I'm wondering how those lessons that you took away might be useful in thinking about how to rebuild trust today across the nation.
Yeah, my dad used to always talk in bullet points. So I think I always break things down into bullet points. And so I think trust isn't just this kind of, butterfly that we chase. Trust is built on a really accountability and communication. So this is part of the reason I've leaned very heavily into the data space. I think to be accountable, we have to have clear data and information. And I think early on in the pandemic, we had very little of that. We see a lot of that in the public health data infrastructure. I got so much more information from my healthcare partners than my very anemic public health response team because of the way data systems were set up and to be able to see information. So it's very hard as a public health professional to be accountable to data when you don't have the data and you don't have the information. There are many mistakes that I made, that our team made, that public health made in general during the pandemic and continue to make, and we continue to learn, and being able to speak about that accountability, but really investing in how do we become as transparent and accountable. And then the other one's in the ways that we communicate. And again, that's the way we communicate individually, our teams communicate, but the ways that communication, again, is building that partnership. I also think that in any big system that you want change, you really need to involve what I've referred to as the 5 Ps. So providers, patients, but also policymakers, the public, and the press. And so I would oftentimes go through my mind and say, have I checked all of those boxes? If I'm communicating to the press about this space, have I told the healthcare providers in a way that is actionable for them, something they can do? Have I told patients on something that they can do in this space? Have I worked with public, everyone from community-based organizations to our tribes to, public advocacy organizations who can help to share those messages in different ways? And our policymakers, what policy levers do we have? So I think oftentimes we look at each other and say, oh, you're the state or you're the federal government. And the reality is we are all the state. We are all this country, and we all play a role in it. In what way can I communicate to each one of those? And I think when we share in that kind of unified space where we all play a role in it, and there is agency and autonomy. I'm not here to be paternalistic and tell you how to live your life. I'm here to listen to your challenges and provide the information and science and data that we know at this time to find a partnership together. I think that's how we build trust. It's really being accountable and communicating, and remembering that communication is as much listening as it is talking.
I love that framing of to the extent possible, and often maybe more possible than we thought. If we can provide the space for autonomy, that might be a better approach. And there have been policy debates recently about if we hadn't had such a compliance-driven, such a restriction-driven approach, might that have created a better space for collaboration? I mean, we'll never know the answer. What do you think?
I think it's harder up front. I think it takes more time and effort, but I think it is so worth it in the end to provide a collaborative rather than top-down approach. Yes, we do have laws and we have regulations and we have speed limits and we have, seatbelt laws. There are laws and regulations, but most of that is done because people don't want to get in a car accident. They stop at the red light, not because a cop is sitting there, but because they know that they're letting someone else take their turn. I think most people make really good decisions on a regular basis in a car, not because someone's there to enforce it, but because they understand those rules are there for their safety and the safety of their community, and they're trying to make the best decisions for both of those. And so we wait patiently at a stop sign. So I think you can have both education and rules or restrictions or whatever that looks like, particularly in high-risk situations like driving a car. But I think the more that we can rely on autonomy, the more we can rely on education, the more we understand the why of a reason, the more we're able to lean into it. And honestly, I'm one person, and my team is just, they've got their perspective and their subset. It was fascinating during COVID. People will be like, well, I know this virus just started, but what's the safest way to do Taekwondo? And I'm like, I have no idea. I cannot.
Outside in the winter?
I don't know. I can give you some generalizations. I don't even know enough about Taekwondo to help you. Or swimming was another great example.
Yeah.
They'd be like, if I put up this barrier, I'm like, I don't know how long you stand on that space. We don't know enough about the virus. I need you to learn about your space, and I can tell you the generalization of it, but then you need to move into it. But it was fascinating. It was really interesting. Early on in the pandemic, I got a lot of criticism for leaning in on education. So the first time I ever went viral, which was a whole different experience, which I was not expecting, is I went for a run and I made a little video of how to go for a run and what does this look like. And I was specifically speaking to Alaskans. So we had, really stay in your community, don't go to another community. So I filmed myself in the car. I'd driven down there and my friend drove in her separate car. And we got out of the car and we stayed apart and we went for a run. And I ran past a camera that I'd set up on a tripod, and I didn't have a mask on because we were 20 feet apart. We were outside. And I was like, stay safe, be well, Alaska. And, it went all around the world. It got millions of views in a short period of time. People were like, she's not in her house. She's not doing this. She's not doing that. And they applied all these restrictions. And I understood, people were frustrated that they were doing it and very fearful. But we also, I really feel like had to educate about what we knew about the virus. If this virus is going to kill us 20 feet apart outside with one other person in Alaska with nothing else around for miles, we were doomed. So I'm still going to go for a run. There were limitations on what we could and couldn't do. And I wanted to encourage that physical health, the mental health space. So it was really interesting. I had healthcare providers tell me, I didn't care if children died because you won't put these restrictions. Like, I care deeply, and I'm seeing patients on a regular basis. And I had the other side saying very loudly that I had closed their business or I had caused them to go bankrupt, and we had no restrictions on their business or their aspects. So there was just all of these different things at play that people like to blame each other for. But I found again and again, when you leaned into the common good and education, I mean, I feel very fortunate. I've worked in the state as the chief medical officer for almost 5 years now, and it's been a joy, an incredible reward. And while I got death threats, I would call the people who gave me death threats, and I would say, tell me more. Help me understand this. Well, tell me, like, are you really? And they're like, oh, that's not what we meant. We just meant we are frustrated our business closed. And I'm like, well, when you say it this way, this is what's responded, and this is what's come in on email, or this is what's come on Facebook. And they're like, oh, that's never what I meant. And they were able to kind of talk to the people who had sent those messages and say, that's not what I was saying. So oftentimes I just find if you lean into the problem, you're able to solve it in so many more ways than if you just put up walls between each other.
I loved the example you brought of the tribes being at the table at every step of the way. And I also think there are probably innovations that you came up with, both accommodating this particular unique landscape that you're in, and also with those partners that are so embedded in that landscape. What are some examples of things that really touched your heart or were really innovative that happened as a result of those partnerships?
Yeah, the ability to work with the Alaska Native people, the 229 federally recognized tribes in the state of Alaska, was probably the single greatest joy, place of learning and reward that I had in this past 5 years. There is incredible innovation happening. There are systems that the rest of the world is looking at, and the lower 48 could benefit greatly from looking at. There is ways that individual autonomy and sovereignty and true democracy and feedback are taken into account. And I got to see that time and time again. I also got to see the way that Alaska Native tribes really remembered history. So the 1918 pandemic devastated much of Alaska. In Dillingham, the hospital is built in the orphanage from the 1918 pandemic. So literally built into the walls is that history. But there was such memory of that disease, there was such memory of that great death, that directly influenced the way that we were able to approach COVID. And it completely changed the way that we worked with the seafood processing industry. It completely changed the way that we worked with travel and communities. So being able to not only bring in the history, which I worry that in so many ways we have forgotten the history of public health. Like right now with syphilis, people are like, what do you mean it's coming back? And people don't know that it used to be required that you got syphilis tested before you got a marriage license. Like people have forgotten all of this great history of public health. But the Alaska Native tribes have not forgotten that history. So they carried that history and they carried it through. And then also because of this nation-to-nation agreement, there is real structure to making sure that you have tribal voice included in decisions. And so if that's tribal consultation, if that is regular tribal partnership, it's critically important. And it's messy at times, it's imperfect, it's frustrating, it's slower, but I really truly believe it makes for a better way of doing things and a better system. So early on in the pandemic, we were all sending testing to the same area, or we were not sending it to other areas, and we were stepping on each other's toes. And we were like, we have to get a way that we're more organized together. So all of the tribes are actually represented in these tribal health organizations. So we set up regular meetings. We had these regular IHS meetings. So fast forward to the vaccine process, we said, let's take what we've learned from this experience as well as our SHIP plan, our Healthy Alaskans 2030, and let's build our tribal partners into every single component of our vaccine allocation team. So from data to shipping to allocation, let's build them into it. We also had a public process. We had other input process. We had lots of other processes like other states, but we directly built our tribes into that response. And as a result, all 229 tribes opted to come with the state. And so we were able to pool our vaccine, our resource. And so then when vaccines started to roll in, we would see it come in, we would help get it out to community. It was both state vaccine and tribal vaccine. And then you would see dog sled going house to house to bring it to elders. You would see man baskets swinging between shipping vessels to be able to vaccinate these gigantic shipping vessels that had been completely isolated. You saw communities prioritize the last language bearers in that community. You saw pilots being able to be vaccinated early because they were moving pregnant patients between communities. And so that was a critical part of their infrastructure in a different way. And so we just saw the power of local communities problem solving day in and day out and doing just tremendous work. The weather change, we couldn't go out on planes. So we talked to my friend who owns a boat and we went out in these 20-foot seas and we got it to the community and we vaccinated. And these are the stories that we had. So we, again, didn't have to problem solve. We can't know all of this at the state. We cannot solve all these problems at the state. But we need to create these team of teams. We need to, as General Stanley McChrystal says, we need to disseminate the information as broadly and wildly as possible and empower communities to be able to be healthy and well. And then they can just do remarkable things that are just amazing to sit back and watch.
So I feel like I was just watching the trailer of the movie that's going to come out about COVID in Alaska.
It was remarkable. It was totally remarkable to watch what communities did in this space. It was inspiring on an everyday basis.
Interesting. The term you just recently ended as the president of ASTO, which stands for the Association of State and Territorial Health Officials. Your priority was to better braid public health and healthcare through data, payment, and mental health. And I'd love to have you just talk about what that means. What is that goal, that ambitious goal that you came in with? And then after that, we'll talk a little bit about what was accomplished and what's still left to do.
Oh, great. There's still lots left to do, for sure. Again, I came in as a burnt out, frustrated, practicing emergency medicine physician where I saw all good public policy come to fail. And I was very passionate about that if I was going to survive in the profession of healthcare, but more importantly, if my patients were going to survive, we were going to have policy change. And so that's what really got me initially into policy, which then got me into public health. And my work between the emergency department and public health very much feels like, in public health, we talk a lot about the metaphor of seeing someone in the river and pulling them out and seeing someone else in the river and pulling it out, and then finally going upstream and understanding why someone fell into the river and helping to build the bank or to fix the bridge or whatever metaphor you want to use. In the emergency department, I feel like I work my night shifts pulling people out and then my day looking at the bridge. And so I literally get to walk up and down this bank of public health to healthcare system and see what's happening and how it falls. I say, who's in charge of this mess? Oh, me. I am. Tomorrow. That will be my job. And I'll say, did that work? And then I go back downstream and I try to figure out how to make it work. So that balance between that has been this real honor and privilege, but it really highlighted to me the different ways in which our healthcare system and our public health system do not talk together, do not work together. And the analogy I oftentimes think of or feel like this represents is like this gigantic wound that has been created. And the wound has been epithelialized, it's been reinforced over and over again because both are wounds that are open. The amount of cost in healthcare, the burnout in healthcare, the lack of funding, just these ebbs and flows, the burnout in public health, both have epithelialized. They've hardened around each other. And it's become really hard to reach out and to find that healing. And we stitch it together in funny ways. Like EMTALA, to me, feels like this gigantic stitch between public health and healthcare. We're going to see people and stabilize them and treat them. But because that's the only stitch really holding us together, we see emergency departments boiling over with patients. We see massive burnout. We see huge healthcare costs. We see people going bankrupt all the time because of the lack of ability to pay for healthcare. So I think that that's this one stitch that's breaking under that space. And so really my focus was, how do we think about healthcare and public health and stitching them together at every single level so that we don't have a wound anymore, but we have a health system that really focuses on what makes people healthy and well. And that's why I specifically called out the mental health space. I joke that physical health and mental health are one and the same in every single way except for how we pay for healthcare. And so what ways we can really think about that whole person health. And the reason I really called out data specifically in there is because both healthcare and public health are data driven. And we really need that data to understand, but we don't even speak the same language. I will see 9 different data elements entered by my nurses for a COVID test in the healthcare, and I will see only 3 of them cross over to my public health team. And then they've got to call the patient and get the additional one. So my poor nurse on the front line is getting tired and exhausted and 5 clicks to crazy until she can't enter one more thing and is burning out. And my public health team doing the exact same thing, simply because we have not stitched together these wounds. But how do we focus on what's best for the people we serve, and how do these different skill sets help to get us there?
So as you think about that agenda, what did you feel really started to gain traction since then? And where are you feeling like we got to give this a bigger push?
Oh, yeah. A lot of my focus initially was very much within ASTO and working with the other state health officials. So simple little things. Instead of having mainly CDC present to our state health officials calls, how do we have HRSA? How do we have SAMHSA? How do we have the FDA? How do we have these other gigantic players in the healthcare sector and space that play a huge role in population and public health be a part of it? So those were small ways. Who's just literally presenting on the calls to be a part of the conversation? In thinking about the data space, working with the Center for Forecasting and Analytics and the data modernization work that's happening at CDC in combination with Civitas and HIEs and this conference and private entrepreneurial. I had this venture capitalist come up to me and she was really great. And so she's listening. You're awesome. But she said, why as a state don't you have an app on the phone so that I could see the respiratory burden in the state? And I said, did you ask the Department of Transportation to make Google Maps? No. And nor would they be able to. I think the things that we're asking of public health aren't fair. We can't do it all on our own. And so, we have annual appropriations for weather data and for economic data. We have none of that for health data. And so we have all these health data silos in this space. So what are those key components that make us healthy? And how do we build on that so that the private sector can engage, the public sector can engage? This is not a tech problem. This is a policy and a cultural problem. But really, the infrastructure grants that came through, the data modernization grants that have come through, it's not sexy. A lot of people haven't seen it, but it is making a huge difference and helping to make sure those data streams are moving through. How does CDC simplify the reporting requirements that they have to do? One disease requires on the average of about 2.5 different data systems to report it. And that's just one disease. And a person might have more than one disease. And that takes on average 2 hours of manual entry per case per health department. So you think about something like measles, which we're now seeing outbreaks in numerous states. It's one of the most contagious viruses we have. And so, one state was sharing with me that they had 2 active patients. They were following 196 different patients who had been exposed. So if you think about that, for each one of those, they're entering at least 2 hours worth of data and interviewing those patients on 200 patients for just 2 cases. And right now we've got 35 states impacted and even more coming soon. That's a lot of time and that's a lot of effort. So what ways can we streamline that data? So it's both where I think we've been successful in using that modernization, but where we still have a really long way to go.
Interesting. One of the examples you gave was what would be today's EMTALA. So for listeners who don't know about EMTALA is the rule that requires any hospital with an ER receiving federal funds to stabilize any patient, as Anne said. And so I love this question of what would be the equivalent way to use the muscle of the federal government and the funding of the federal government to better stitch together medical and public health. What's the modern day EMTALA?
It's a great question. I think there's a lot of debate on it. Most people don't like to think of conditions of participation. It gets a lot of people angry very quickly. So I'll acknowledge that. Sorry, CMS. I know that people don't love that conversation, but I do think it is a really large tool. I think there's a series of tools to get there in different ways. So, for example, when CMS came out with the postpartum Medicaid extension, we now have 48 states that have moved forward and made that coverage for a full year. And so even states that had not expanded Medicaid opted in to do that because they saw the challenges in morbidity and mortality in the postpartum term and what that looked like, as well as the challenges of having a baby and mom not having their reinsurance at the same time. Like, just put them together. I know when I had kids, redoing my insurance at 2 months was not like a top priority. So having baby and mom just know that they just got to redo their Medicaid a year together just makes a lot of sense in a lot of ways. You can remember the birthday, you can just go forward from that space. And so we've seen that was a great example to me of where CMS said, we will approve this if it is done. And some states, like my state, needed to go through the legislature. Other states didn't. Whatever. We worked it out through all of our own sections, but you just saw the rapid uptake. That was much easier than something like a demonstration waiver, which honestly takes millions of dollars to do all the actuarial work and say, I want to demonstrate to be able to do this differently. States like Alaska, small states, don't have the funds to be able to do this. So if I think we see those similarities, that makes a lot of sense. And then how can we braid on top of that conditions of participation on key sharing of data elements, key efforts in public health that need to be done? So instead of each state having a separate reportable condition, how can we say that these are the standard reportable conditions? States can add on top of it if they wish to, but that every state is going to be able to share regularly with their public health. And so when I hear from the private sector, like the hospital sector, who says, I cannot figure out all of your different jurisdictions, and I got to report to this state this and this state this, we're creating great inefficiency, which creates cost for the healthcare sector by having all these separate public health requirements. And public health gets frustrated because all the healthcare industry has their own separate ways of reporting. So I think that if we were to say there are some basic data elements that we need to be able to share between local public health, state public health, and data elements within healthcare, that is one component of it. I think there could be other things, such as being able to offer certain vaccines in community or in the hospital. So this came up a big component with the new RSV monoclonal antibody that is best done right after birth. But most hospitals are not in the process of routine vaccination and not a part of that plan. So thinking about what are kind of those key data elements, what are those key actions that you want those who participate in Medicaid and Medicare to do as a part of public health, I think is going to save us a lot of money because healthier people are cheaper people. And there are key basic public health needs that I think could really stitch us together. So there's a lot of debate on how big or small you go, depending on how big you think. But I think we need to be having the conversation.
I love it. You recently announced that you'll be stepping down. And I'm sure that's bringing a lot of very mixed feelings. What are some of the paths you want to deepen and work on and think about as you look forward to the next year or so?
Yeah, thanks for asking that. It was a really hard decision to make. It's been the honor of a lifetime to serve in this role, and I am going to miss it tremendously. But we each have a place and a time, and I always joke that I'm trying to work myself out of a job, and my team is great, and they're doing fantastic things. And I increasingly feel like Dumbo's feather. They don't need me to fly, and they are fine, and they are doing great things. And it's time to realign some of my energy and effort and attention into new areas, because that's what excites me the most. I think this intersection between public health and healthcare and how do we provide better data to provide better patient-centric care is really a passion point of mine that's always been there. It's just come out in different ways and in different times. I'm incredibly thankful for my kids and my husband giving me a lot of time and flexibility to serve during this time. But immediate plans is to spend a little bit of time this summer with them. As I mentioned earlier, I was a fine arts minor, and I think the negative space is as important as the positive space. And so having a little bit of time to kind of reflect and to process, and then to be able to put my heart and soul into the next steps is key. I don't know what that looks like, but to me, it's really about how do we braid systems to work for patients instead of asking them to navigate all of this craziness.
I can't wait for both the stories of your break as well as whatever comes next. So my last question is, I recently took a new role at the UC Berkeley School of Public Health as their first ever Chief Social Impact Officer. So my question for you is, what advice would you give me about some of the biggest opportunities to have schools of public health be a more powerful force of change in the world?
Well, first of all, congratulations. I'm super excited to see what you do in that space. It's been really fun to watch schools of public health engage in really different ways. Honestly, since the pandemic, from my perspective, I think there's a lot of this questioning and what makes us impactful. A couple different things. One, at the end of the day, we want better outcomes. And so how do you make sure that public health is accountable? How do you make sure those outcomes are there? So how do we make that research to action? What does that look like? I think bringing healthcare into the space, not just having that conversation with public health, and you have that experience with working with Medicaid and different systems, bringing people who've worked in public health to come back and share their perspectives and experience. But more than anything, building in the structure to hear from communities on a regular basis. Again, I look to the tribes in Alaska. There is successes and weaknesses. Nothing is perfect. But, you look at the Nuka model in South Central Alaska and the way that they built in behavioral health in combination with physical health and the outcomes that they have associated with that. The blanket exercise that actually came out of Canada to understand kind of the history in a community and how that impacts the decisions that are made now, to thinking about cultural relevance of mental health conditions and our mental health aides and our community health aides in Alaska, I think are doing tremendous work that I think could be replicated in other areas. So I oftentimes am in the lower 48 and people will be having conversations about community-based organizations and making sure that community is at the center. And my mind immediately goes to thinking about our tribes and the ways that financially is structured, the way that we are really required to partner, and the real strength that provides us as a state, but then also the community for thinking about whole person health and the potential next steps moving forward.
And maybe those are things we can bring more centrally into this conversation on the podcast as well.
Yeah.
So thank you so much, Anne. What a gift to be able to take this moment with you at the end of a long day. So thank you.
Yeah, it's a huge honor. I came from the ASTO conference in DC, making my way back up the West Coast and headed to Juneau tomorrow to do some more legislative work. But it's great to have this time to be able to talk to you. I've loved your questions, and I really appreciate you thinking about all the things that make us healthy and well, not just in the healthcare space. So thanks for the work that you're doing.
As a data leader in California during COVID, I saw firsthand how the silos dividing medical care and public health slowed our pandemic response and harmed people. They were two separate worlds connected only by, until then, rare reportable diseases. Yet in the end, promoting health means thinking in a holistic and integrated way about the two. Or in Anne's words, braiding public health and healthcare together. For instance, how can Medicaid conditions of participation help us reach our public health goals? And how might we build a health intelligence data infrastructure serving both public health and medical care? This podcast was created by me, Claudia Williams. My podcast producer is Avery Moore-Kloss. Check out the show notes for more information about Dr. Anne Zink. There is more information on my background, this podcast, and our guests on our website, www.theother80.com. Until next time, I'm Claudia Williams.